Welcome, colleague, to this rapid-fire explainer to high-yield clinical algorithms. We're skipping the fluff and jumping right into the material today. We're looking at an integrative mixed-block simulation, and it's calibrated strictly for those of you aiming for top-tier, perfect clinical mastery. We're going to break down intricate mechanisms, strict management steps, and the precise diagnostic traps you absolutely need to avoid. All right, let's dive right in. So we have to start aggressively right out of the gate with an absolute, non-negotiable rule. In any presentation of suspected urethral trauma, the placement of a Foley catheter is absolutely contraindicated. No exceptions. Why? Because blindly passing a catheter can catastrophically convert a partial urethral tear into a complete transection. It's just not worth the risk. You must secure diagnostic imaging first. If you see signs of urethral trauma, literally step away from the Foley.
Module 1. Urethral trauma algorithms. Let's clearly differentiate the mechanisms of injury here.
You know, the mechanism of injury really dictates the exact anatomical location of the trauma. Looking at posterior disruption, specifically of the membranous urethra, this is strictly associated with high-impact kinetic events. We're talking severe motor vehicle crashes leading to pelvic fractures. Now compare that to anterior shearing, which involves the bulbar urethra. This one is strictly driven by straddle injuries. Think of a patient falling hard onto a bicycle crossbar, or maybe a fence. This anterior injury typically presents with a massive localized perineal hematoma. For those high-impact posterior injuries, you absolutely must memorize this diagnostic triad. It's blood at the urethral meatus, the inability to void despite having a palpable urge, and a high-riding prostate on a digital rectal exam. Now, the crucial point here is understanding why the prostate is high-riding. It happens because the massive force of the pelvic fracture literally shears the puboprostatic ligaments. It detaches the prostate and allows it to just float superiorly right up into the pelvis.
And this brings us to our diagnostic mandate. When you see that triad, or frankly even just blood at the meatus after blunt pelvic trauma, your immediate, non-negotiable next procedural step is a retrograde urethrogram, or RUG. We're talking about injecting contrast directly into the urethra to visualize its structural integrity. You are actively hunting for extravasation of contrast before you ever even think about touching a catheter.
To synthesize this module, let's look at the clinical variance box here. The mechanism variable dictates the injury location and the strict management pathways. Both scenarios require a URUG for diagnosis, for sure. But remember, an anterior straddle injury damages the bulbar urethra, while a high-impact pelvic fracture damages the posterior membranous urethra. Identifying that mechanism immediately sets your diagnostic logic on the exact right path.
Module 2. Bladder Rupture Kinetics. The same kinetic forces that break the pelvis also wreak havoc on the bladder in two very distinct ways.
We've got to contrast two clinical scenarios here. First up, the extraperitoneal leak. This is almost exclusively caused by pelvic fracture bone spicules physically piercing the anterior lateral bladder wall. The leaked urine and contrast strictly pool locally, right there in the retropubic space of Retzius. Second, we have the intraperitoneal catastrophe. This is driven by massive compressive force on a fully distended bladder. Imagine a seatbelt compressing the abdomen in a high-speed crash. The bladder dome, which is the only segment actually covered by the peritoneum, literally blows out.
So this management matrix outlines exactly why that anatomic distinction is a matter of life and death. If imaging shows an extraperitoneal rupture, management is overwhelmingly conservative. You're going to place a Foley catheter for prolonged decompression and just allow the bladder neck or anterior wall to heal. However, if contrast strictly outlines the bowel loops on your imaging, well, you are dealing with an intraperitoneal rupture. Urine is literally flooding the abdominal cavity, causing chemical peritonitis. This strictly mandates an emergent surgical laparotomy for repair.
Let's isolate the singular clinical variance point here. Extraperitoneal stays localized in the retropubic space and heals safely with a catheter. Intraperitoneal involves the dome, floods the abdomen, and absolutely requires the operating room. You have to know the difference in mechanism, the difference on imaging, and ultimately, the difference in the surgical threshold.
Module 3. Vulvar dystrophies and oncologic risk. Maintaining our clinical momentum here, we must master these critical dermatologic and oncologic distinctions.
Let's contrast the atrophic destruction of lichen sclerosus against the hyperplastic thickening of lichen simplex chronicus. Lichen sclerosus is this severe autoimmune thinning of the epidermis. The strict physical exam finding here is cigarette paper, parchment-like skin, often with a pathognomonic figure-of-8 perianal halo.
On the flip side, lichen simplex chronicus is a mechanical issue. It's driven purely by a chronic itch-scratch cycle, which results in thickened, leathery, hyperpigmented skin strictly due to that constant friction.
Now this is absolutely the most vital takeaway for this module, the malignant conversion risk. Lichen sclerosus carries a massive recognized risk for malignant transformation into vulvar squamous cell carcinoma. Because of this massive oncologic risk, the management algorithm strictly mandates an initial punch biopsy of any suspicious lesion just to rule out malignancy. Following a benign biopsy, the patient requires lifelong management with high-potency topical corticosteroids like clobetasol to halt the architectural destruction. To wrap up this module, take a look at our variance box. Both conditions present with chronic pruritus and skin changes, sure. However, only lichen sclerosus causes autoimmune architectural destruction, severely thins the skin, and carries that high SCC risk. Lichen simplex chronicus, on the other hand, simply thickens the skin mechanically and has zero malignant potential. Your biopsy and treatment thresholds hinge entirely on this specific distinction.
The master case. Testing integration. All right, it is time to put it all together and look at the structural blueprint of a high-stakes clinical assessment.
Here is our patient profile blueprint. We've got a 25-year-old male brought in following a severe motorcycle crash. He has a confirmed pelvic ring fracture, gross hematuria, and suprapubic fullness. But notice how this vignette is engineered to test your discipline. We embed a diagnostic trap. The digital rectal exam reveals a completely normal-feeling prostate. However, there is a single drop of blood at the meatus. So what is the absolute next best step in management? Simulating actual high-pressure exam conditions, here are your 5 highly competitive answer choices. Number 1, CT cystogram. Number 2, suprapubic catheterization. Number 3, Foley insertion. Number 4, intravenous pylography. Number 5, retrograde urethrogram. The prompt strictly demands the absolute first procedural step. Do you fall for the trap, or do you stick to the algorithm?
Let's map out the correct clinical logic by walking through strict trauma sequencing. Step 1 in an unstable pelvic fracture is always mechanical stabilization, like applying a pelvic binder. Step 2, before any lower urinary tract intervention, is the retrograde urethrogram to rule out urethral transection. Only after the urethra is definitively cleared in Step 3 do you proceed to catheterization or surgical repair.
Let's systematically dismantle the incorrect options to enforce this exact procedural nuance. Choice 3, Foley insertion, is absolutely contraindicated due to that single drop of blood at the meatus, regardless of the normal prostate exam. The mechanism of a pelvic ring fracture dictates high suspicion. Choice 1, CT cystogram, evaluates the bladder, but you literally cannot safely pass the necessary catheter to fill the bladder with contrast until the urethra is cleared. Choice 2, suprapubic catheterization, well, that might be the eventual treatment if the urethra is completely transected, but it is way too invasive to be the first diagnostic step. Choice 4, IV pyelography, visualizes the kidneys and ureters, not the lower tract trauma we suspect here. Therefore, choice 5, the retrograde urethrogram, is the irrefutable first step to definitively grade the urethral injury.
We'll end on this provocative thought for your clinical practice. When you're managing high-velocity, multi-system trauma, do you trust an isolated physical exam finding, like a normal-feeling prostate, or do you trust the irrefutable, massive kinetic mechanism of injury staring you right in the face? A normal DRE just does not rule out urethral injury when the pelvis is shattered. Always respect the mechanism, follow the strict algorithms, and never, ever place that Foley blindly. Thanks for joining me on this explainer, colleague. Keep mastering the fundamentals.